Hello and good afternoon, everyone. Welcome to MRF HIV STI Echo. I am Dr. Gregory Boyce, your facilitator for the day's proceedings. And I want to welcome Conrad, who is our host with the most, from a little far away, but always happy to have him. And thanks everyone for coming out on a kind of overcast and gloomy, a little bit cold, but still, we're happy to have life, happy to have the ability to serve our patients. And we again welcome Dr. Chris Behrens, who's going to give us a very important topic, because we keep seeing patients like these, patients with cryptococcal disease or suspicion of cryptococcal disease. And sometimes we're not quite sure, we don't have cryptococcal antigens. Sometimes the India ink may be negative, but the CSF looks a little funny, and is this a case, is not a case. So, and given where the mortality is with this, and given how important it is to get the management, down pat in terms of its impact on mortality, it's really important, and that we make sure we have a revision every now and again. And some new guidance have come out, so it's a really important learning session today. So Dr. Behrens, thanks again. A really important topic, and it's in the floor with you.
Okay, thank you very much. It's always a pleasure to be invited to present on for these sessions. So without further ado, I will proceed to talk with this talk. Let's see. I have no relevant financial disclosures. Our learning objectives, hopefully by the end of this, you will be able to describe epidemiology, clinical manifestations of cryptococcal infections in persons living with HIV, and review some recommendations regarding the diagnosis, prevention, and treatment of these infections. In terms of epidemiology, Cryptococcus is a fungus that is found worldwide. And there are variations reported. I'm not sure whether those they probably do reflect some true difference in prevalence. Some of this may be sort of reporting discrepancies and diagnosis challenges, but Cryptococcus exists everywhere. It's in the soil. Most cryptococcal infections in people with HIV are caused by C. neoformans, although C. gatti is another causative agent that we see here in the United States and Australia. Wouldn't be surprised if you see it in Trinidad as well. And it is an important source of mortality. It causes 15% of AIDS-related deaths globally. So let's talk about the different clinical manifestations, because while we tend to think of cryptococcal meningitis, there are other clinical manifestations and sites of infection. Dermatologically, cryptococcal infection can manifest as these umbilicated pustules that look a lot like molluscum contagiosum. So, if you have seen that, which is not uncommon among kids, and actually also not uncommon among people with HIV, always think, could this be actually Cryptococcus? Now, if we are dealing with just cutaneous infection with no evidence of dissemination, treatment involves just fluconazole daily for 3 to 6 months. There are alternatives, including amphotericin or itraconazole. However, if we are looking at a disseminated cutaneous infection in an immunocompromised host, if other organ systems are also involved, or if the serum cryptococcal antigen is positive. So in other words, if we have any concern about a more disseminated disease, then we treat as if this were a cryptococcal meningitis. And of course, we'll get to those treatment protocols. Now, Cryptococcus generally starts in the lungs. That's how it's often inhaled. And it is possible to have isolated pulmonary infection. Clinical presentation, cough, shortness of breath can be severe with adult respiratory distress syndrome, or ARDS. Usually the chest X-ray shows a lobar consolidation, such as seen here, but it is possible to see sort of nodular infiltrates or little fungus balls in the lungs. This is an example of those nodular infiltrates in someone with cryptococcal pneumonia. It's pretty widespread and bilateral. Now, these guidelines for treating cryptococcal pneumonia come from the Infectious Disease Society of America. So again, if you have someone who's immunosuppressed who has evidence of pulmonary disease, you really need to rule out cryptococcal meningitis with a lumbar puncture. Pneumonia that is associated with CNS or disseminated disease, or if it's severe enough, you treat it as if this were a central nervous system infection. And you may even want to use steroids if ARDS is present in the setting of immune reconstitution inflammatory syndrome, which we will also touch on later. For mild to moderate symptoms, if you don't have diffuse pulmonary infiltrates, not severe immunosuppression, no evidence of disseminated disease, it is okay to use just fluconazole for 6 to 12 months. And there are alternatives that can be used if fluconazole is not available or contraindicated. For these pulmonary cryptococcomas or fungus balls, if it's just a single small one, you can use fluconazole 400 milligrams daily. But if they're large and multiple, you have to be more aggressive with the treatment. You might want to combine amphotericin B and flucytosine for 4 to 6 weeks, followed by fluconazole. And surgery may be indicated because these can be quite large. They can start compressing vital structures like the major blood vessels around the heart, for example, or surgery may be indicated if antibiotic treatment is not reducing the size of these cryptococcomas. Now, in people with HIV who are on ART, who have a CD4 count over 100, and their serum cryptococcal antigen titer is less than 1 to 512 or not increasing, it is reasonable to stop that maintenance fluconazole after 1 year of treatment. So these are the basically United States guidelines around cryptococcal pneumonia. Cryptococcal meningitis, this will be the majority of the material I'm going to present. This condition presents typically with fever and headache and malaise. And often it's, kind of a gradual subacute presentation. It can go on for a while. It's a bit different from your typical bacterial meningitis, which comes on sort of more quickly, more acutely. And moreover, with cryptococcal meningitis, we often do not have these classic meningeal symptoms such as neck stiffness and photophobia. Those occur in only 1/4 to 1/3 of patients. But patients with cryptococcal meningitis do often experience the encephalopathy symptoms like lethargy, altered mentation, even personality changes or memory loss. And usually these are a result of the increased intracranial pressure that so commonly comes with cryptococcal meningitis. So how do we diagnose cryptococcal meningitis? Well, it can be diagnosed through culture of the cryptococcus, CSF microscopy, if you can actually see it with staining, or by detection of cryptococcal antigen in the cerebrospinal fluid. Now, culture, 55% of blood cultures and almost all CSF cultures in patients with cryptococcal meningitis will be positive. Detectable, visible colonies can usually be detected within a week in these individuals. In terms of the CSF microscopy, India ink is the common staining technique that is used, and this will demonstrate the yeast in about 60 to 80% of cases. So decent sensitivity, but you can't miss this if you just rely on the microscopy. Serum cryptococcal antigen has a very, very high sensitivity and specificity for cryptococcal infection somewhere in the body. The problem is a serum test doesn't tell you exactly where. So it can be a very useful initial screening tool in at least detecting whether or not we have cryptococcal infection somewhere in the body. But a positive serum cryptococcal antigen test is not enough to diagnose CSF infection. And you really need a lumbar puncture as the next step to rule in or rule out meningeal disease. So ultimately, the way we usually diagnose cryptococcal meningitis is by getting a positive CSF cryptococcal antigen test. And among people with HIV who have cryptococcal meningitis, the CSF tests are going to be positive in over 95% of patients. And often these titers, because it's, we measure titers with this similarly as we do, say, with syphilis and RPR titers. These titers are often greater than 1 to 2048. So very high titers are common. There are other tests that should be performed on the CSF when it's drawn, not just cryptococcal antigen tests, but also fungal culture, glucose, protein, cell count, gram stain, and bacterial culture. Viral PCR might be considered too if you have that available and the clinical picture fits, because you do want to make sure you're not missing, say, a bacterial meningitis. Now, unlike bacterial meningitis, however, most people with HIV who have cryptococcal meningitis are going to have a relatively low white count on the CSF. And that's because this occurs in advanced HIV disease, and there's not much of an immune response coming from a depleted immune system in someone with very late stage HIV infection. The other key point is that you need to measure the opening pressure at the time of the lumbar puncture in everyone with suspected cryptococcal meningitis. And most patients will have an elevated pressure. Measuring that opening pressure is not that difficult. Most lumbar puncture trays and kits come with the equipment that's necessary to do this. And all it involves is placing this vertical tube on the stopcock that is attached to the needle that penetrates into the CSF. And you simply, dial make sure the orientation of the valve is correct, and the pressure will drive the CSF up against gravity to a certain level, and you get your measurement of the opening pressure in that way. And then, of course, you can drain the CSF as well for all the tests that need to be performed. So just keep things interesting. I'm going to include a few sort of questions and polls throughout the test and throughout the study that I'm talking about. And this is one of them. So, which of the following is true of elevated intracranial pressure in patients with cryptococcal meningitis? A, steroids or acetazolamide can be used to safely reduce elevated intracranial pressure in people with HIV with cryptococcal meningitis. B, reducing the intracranial pressure has been associated with improvements in mortality in these individuals. C, therapeutic lumbar puncture should be repeated daily in symptomatic patients until symptoms and signs consistently improve and opening pressure normalizes to less than 20. D, statements A and B are true. E, statements B and C are true, or F, all of these statements are true. And we have one, this is anonymous, so please feel comfortable to respond. Okay, we got two responses so far. Do we have any other takers for this question? All right, well, for the sake of time, let's just end the polling now and share the results. Let's see. I'm not seeing the results. Are you seeing the results? Oh, here we are. Let's see. We had two responses. And the correct response is E. That is, statements B and C are the correct ones. Reducing intracranial pressure helps, and these therapeutic lumbar punctures should be continued. But unfortunately, steroids or acetazolamide don't help. So we really have to do the manual opening of pressure and draining the CSF consistently to bring down the pressure. And this is important because the changes in pressure that are seen in people with cryptococcal meningitis do correlate with clinical outcomes. So this chart sort of summarizes what happens in terms of clinical failure or mycologic failure, according to whether or not the CSF level pressure went down, stayed the same, or went up over the course of treatment. And as you can see, if the pressure went up over the course of treatment, significantly higher rates of clinical failure and mycologic failure as compared to those individuals in whom the opening pressure went down over the course of treatment. So the United States guidelines around this state that people with HIV who have suspected cryptococcal meningitis should have an initial LP and an early repeat LP, measuring the CSF opening pressure, regardless of the presence of symptoms or signs of raised intracranial pressure. So you do this in all patients in whom you suspect possible cryptococcal meningitis. You don't base it according to whether or not signs and symptoms suggest they might. And even if, that, and this is a common scenario where, the opening, the CSF was checked initially, but whoever did it didn't check the opening pressure, do it again and measure it again. It's not too late to do it, after the first time the CSF is drawn. Drainage of CSF is recommended for initial management of elevated intracranial pressure, and it's the only way to effectively lower it. Now, one way to do that, to lower the pressure, is to remove an amount of CSF that at least cuts that opening pressure in half or normalizes the pressure to less than 20. So as you're draining the CSF, you can be checking the opening pressure as you go. If you don't have a manometer handy, if you don't have that, that piece of equipment that very simply measures the opening pressure, well, then remove about 20 to 25 cc's of CSF. Now, among patients with ongoing symptoms, you need to repeat the therapeutic lumbar puncture every day until those symptoms and signs improve and the opening pressure is less than 20. Because there is a survival benefit associated with a draining CSF, regardless of the opening pressure, it's probably a good idea to repeat an LP within 72 hours of the initial LP, even though in those patients who are relatively asymptomatic or whose baseline CSF was less than 20. So even if it was normal when you first checked it, or these patients didn't have a lot in the way of signs and symptoms, not a bad idea, and probably a good idea to repeat it anyway. Within 72 hours, check it again. Some patients need repeated lumbar drains, repeated drainage. And if this is happening day after day for several days, you may want to consider putting in what's called a lumbar drain. It's kind of like, think of it as like a permanent LP with a spigot that you simply open it up every day and it drains it out. And as I mentioned before, unfortunately, steroids, acetazolamide, mannitol, these are not effective in managing intracranial pressure in this setting and are not recommended. The WHO has its own recommendations around diagnosing cryptococcal meningitis, which are fairly similar, but take into account the limitations in many resource-limited settings. So WHO also recommends that prompt lumbar puncture with measurement of the CSF and obtaining a cryptococcal antigen assay is recommended as the preferred diagnostic approach. But helpfully, the WHO provides diagnostic approaches according to context, for example, in settings that have ready access to lumbar puncture, where there's no contraindication to do so, as well as what to do if you don't have immediate access lumbar puncture or if it's contraindicated. So these contraindications to doing lumbar puncture include significant coagulopathy, so very high risk of excessive bleeding, suspected space-occupying lesion based on focal nervous systems and signs, excluding a cranial nerve 6 palsy or recurrent seizures. Ideally, in that situation, you get a CT scan if you can to, in fact, see if there might be a mass lesion. If there's a major spinal deformity that just prevents access, or if the patient refuses despite your best efforts, well, then that's you can't do the LP in that situation either. But it's important to know that in the setting of cryptococcal meningitis, elevated intracranial pressure does not contraindicate lumbar puncture. It's not going to result in herniation the way elevated intracranial pressure in the setting of a mass lesion in the brain will. So if you have ready access and no contraindication lumbar puncture, then the next step is knowing whether you have access to the cryptococcal antigen assay, or CRAG. If you do, and you can get those results quickly, then essentially what's recommended is aligns with the United States guidelines. Do an LP, perform cryptococcal antigen assay on the CSF, and that is the recommended diagnostic approach. If, however, you don't have access to that assay, or you're not going to be able to get results back very, very quickly, i.e. within 24 hours, then do the lumbar puncture and use staining of the CSF to look for evidence of cryptococcal meningitis. Now, what about in settings where you can't do a lumbar puncture, or if it's clinically contraindicated? Well, in that situation, if you have access to cryptococcal antigen testing and a rapid turnaround of it, then that's what you're going to do on the serum. And if the serum test is positive, and this is someone in whom you're potentially concerned about cryptococcal meningitis, then you're just going to take that as your diagnostic test. You're going to proceed with assuming that they have cryptococcal meningitis, even though you weren't able to confirm it on the CSF. If, however, you just don't have the cryptococcal antigen assay, or you can't get a quick turnaround on it, and again, this is where you can't do an LP either, well, then you really need to have those patients evaluated elsewhere where these tests can be done, because you're really sort of stuck in a diagnostic nowhere, no man's land there. Okay, let's shift to treating cryptococcal meningitis. And again, we have treatment guidelines that I'm going to reference from the United States and from the WHO. So again, we've got another poll. I'm going to put you all on the spot here. Which of the following is or are preferred options for the initial treatment of cryptococcal meningitis? A, liposomal amphotericin B plus flucytosine for 2 weeks. B, a single dose of liposomal ampho B plus 2 weeks of fluconazole and flucytosine. C, amphotericin lipid B complex plus flucytosine for 2 weeks. D, fluconazole plus flucytosine for 2 weeks. Options A and B, options B and C, or all of the above. Okay, we've got a couple We got three people who are submitting answers here. That's terrific. So let's go ahead and share these results. And we've got a nice distribution of responses. Some people said A, liposomal amphotericin plus flucytosine, another answer for B, and an answer for G, all of the above. Actually, it's A and B. So option E here, the first two options here are the correct ones that are listed as preferred options, but interestingly, in different sets of guidelines. And this is relatively new either. So honestly, I wouldn't have expected anyone to necessarily get this answer correct. So let's back up for a minute and review, the sort of overview of what treatment of cryptococcal meningitis looks like. It involves three phases. There's the induction therapy, which is typically 2 weeks, followed by consolidation therapy for 8 weeks. And then there's chronic maintenance therapy. And this can continue for life unless your patient gets on ART and has a sustained response with virologic suppression and a CD4 count that exceeds 100. And fortunately, that is often the case. Now, it may be tempting to monitor those serum cryptococcal antigen titers the same way we monitor, say, RPR or TRUST or VDRL titers in people with syphilis, but it actually doesn't seem to work. So we don't monitor serum CRAG titers to monitor treatment in these patients. These are the United States guidelines, and it lists a lot of options, but there are just two preferred regimens that are listed here. One is a liposomal amphotericin B plus daily flucytosine for 2 weeks. The other option is amphotericin B deoxycholate plus daily flucytosine. So very similar. And then, of course, there are a lot of different options. And so what do we mean by this liposomal amphotericin or amphodeoxycholate or amphotericin B lipid complex? Well, the main ingredient, the active drug here, is amphotericin B, right? That's the one that kills Cryptococcus. But the packaging of it can significantly reduce the toxicity and improve the pharmacokinetics as well. So, when I was in training, amphotericin was called amphoterrible because of all the side effects that patients who received it would experience. But when we came up with liposomal amphotericin B or amphotericin B lipid complex, there's something about packaging the amphotericin B within this lipid bilayer, this lipid complex, that makes it significantly less toxic, not just in terms of the fevers and the rigors, but also in terms of protecting the kidneys. So if you have it, the liposomal is preferred because it's much more tolerated. If not, then according to the United States guidelines, amphotericin B deoxycholate is fine, especially if cost is an issue, and there's not much risk of renal dysfunction. United States guidelines also does recommend monitoring the serum flucytosine levels in people who are receiving this drug. It can be checked after 3 to 5 doses, about 2 hours after taking the last dose. And you are going to have to renally adjust the dosing of this in people with renal impairment. Consolidation therapy, and this is a little bit complicated, but bear with me. After the 2 weeks of induction therapy, these patients need to get another lumbar puncture and another CSF culture. Now, if at this point the patient is stable, you can go ahead and switch to the consolidation therapy while awaiting those CSF culture results. However, you can't really say that induction therapy was truly successful until you see both the substantial clinical improvement and a negative CSF culture that you drew at the end of 2 weeks. You can't use India Inc. You can't use CSF CRAG. Those are very frequently positive at week 2. They don't necessarily indicate live organisms. And again, serum nor CSF CRAG titers don't help here. For patients who have completed 2 weeks of induction therapy, but have not improved clinically, right, remain clinically unstable, you should continue the amphotericin B plus flucytosine beyond that, 2-week initial recommendation until the CSF cultures are confirmed to be negative. For patients who have improved clinically, but whose CSF culture remains positive, after 2 weeks of induction therapy, you should go ahead and increase the fluconazole dose that's used in consolidation therapy to 1,200 milligrams per day. Do another lumbar puncture 2 weeks later. For any patient whose CSF cultures are positive week 2, the duration of consolidation therapy of 8 weeks, you start the clock on that from the time the CSF cultures are negative. So it's kind of like you extend induction therapy until you get CSF cultures that are negative, and then you start the clock for the 8 weeks of consolidation therapy. In clinically stable patients, the dose of fluconazole for consolidation therapy should be 800 milligrams per day until the CSF cultures are known to be sterile and ART is initiated, at which point the dose can be decreased to 400 milligrams per day. So there's no way to remember all this, but just reference this as needed. Now, maintenance therapy, according to US guidelines, consists of fluconazole 200 milligrams daily for at least a year after successful induction and consolidation treatment of cryptococcal meningitis. Oral itraconazole is not recommended. Now, after a year, you can stop this maintenance therapy if your patient has no signs or symptoms of ongoing infection and has a CD4 count over 100 and is on antiretroviral therapy with virologic suppression. But if that CD4 count dips below 100, well, then you're going to have to restart maintenance therapy. Okay, now what does the WHO say about treatment of cryptococcal meningitis? It's slightly different. Their preferred regimen is a single high dose, 10 mg per kg of liposomal amphotericin B plus 2 weeks of flucytosine and 2 weeks of fluconazole. And as you may recall, this actually was not one of the listed regimens recommended in the US guidelines. But the rationale for this, somewhat unusual regimen comes from the Ambisome Therapy Induction Optimization, or AMBITION-CM trial that was just published last year in the New England Journal of Medicine. And this study enrolled over 800 people with HIV diagnosed with cryptococcal meningitis from sub-Saharan Africa, and they were randomly assigned to receive either this high-dose liposomal amphotericin plus fluconazole and flucytosine for 2 weeks, or they were randomized to the control arm, which was the standard, treatment regimen, 7 days of ampho B deoxycholate plus flucytosine, followed by 7 days of just fluconazole. And the primary endpoint was death from any cause at 10 weeks after randomization. So a very strong sort of clinical outcome there. And what they found was that the liposomal group was not inferior in terms of all-cause mortality as compared with the control group. The two groups did, about as well, maybe a little bit better for liposomal ampho B, but certainly not statistically significant. And really, they were just trying to see did this newish regimen perform equally well as the control? And actually, if you look at adjusted analysis by whether it's intention to treat or by per protocol, the outcomes actually did appear to favor the liposomal amphotericin group. So perhaps not just non-inferior, but possibly even better in terms of mortality at 10 weeks. The rate of fungal clearance was about the same in the two groups. But in terms of side effects, the liposomal amphotericin B definitely did better in terms of any grade 3 or 4 adverse events or grade 3 or 4 anemia. Significant advantage here to the liposomal ampho B group. So that's where that WHO guideline recommendation came from. You may be wondering, well, why don't the United States guidelines recommend that? Well, this trial was not comparing this regimen against the US standard recommended regimen, right? Which also consists of liposomal amphotericin B, but for a longer period of time. However, it has been argued, and this is something that was just published a few months ago. There are some experts out there who think that, the evidence is so persuasive for this treatment approach, which actually is less complicated and less toxic than the, what's recommended as first-line United States guidelines, that we really should consider using that, or at least including it as an option in United States guidelines. And I wouldn't be surprised if in the next iteration of the United States opportunistic infection treatment guidelines, we may see this published as an option as well. Now, WHO also lists alternative induction treatment options for cryptococcal meningitis, depending on whether or not you have liposomal amphotericin or even no amphotericin at all, whether or not you have flucytosine, whether or not you have ampho or flucytosine. I'm not going to go through all these, sort of options, but they're there. Just know that the WHO kind of lists all these different scenarios depending on which agents are available. In terms of consolidation and maintenance therapy, the WHO for consolidation treatment recommends fluconazole, 800 milligrams per day for adults. It's weight-based dosing for children and adolescents. For the consolidation phase for 8 weeks following induction. And then for maintenance phase, it's 200 milligrams daily or weight-based for adolescents and children. And this is, pretty similar to what the United States guidelines recommend. And it's fairly similar guidance in terms of when one can safely stop maintenance therapy. WHO recommends maintenance treatment for at least a year. If patients achieve virologic suppression and a sustained rise in the CD4 count over 100, it's okay to stop. If you don't have viral load monitoring available, well, then you sort of make sure that CD4 count is over 200 in patients who are on ART and seem to be adherent. They also include language around how to do this for young children. Again, it's pretty similar, but of course the CD4 count thresholds are changed. And for very young children, younger than 2 years, they just recommend against stopping maintenance treatment at all. Now, what if your treatment of the patient with cryptococcal meningitis doesn't seem to be working? This is tricky. There is no simple algorithm here, but these are some of the things that probably should be done. First, try to estimate, adherence. Make sure that the dosing and the treatment periods were appropriately calculated and maintained. investigate, if you can, whether or not there might be fluconazole drug resistance in patients, especially patients who may have received this in the past. It's very important to do another lumbar puncture, check the opening pressure again, and retest the CSF. And in this case, you definitely want to be looking for another possible cause of meningitis besides Cryptococcus. You need to consider the possibility of immune reconstitution inflammatory syndrome, or IRIS, among patients who have recently started antiretroviral therapy and who seem to be worsening. And the CSF that you draw should be sent for a prolonged fungal culture. Give it a good 2 weeks of incubation. These are World Health Organization guidelines, which I think are sensible and apply anywhere. A few other considerations that we should touch on. Immune reconstitution inflammatory syndrome, or IRIS, which I just mentioned in the last slide. This is common in the setting of cryptococcal meningitis. About a third of patients with HIV who start ART around the time of treatment for cryptococcal meningitis will experience this, and it can be life-threatening because this inflammatory reaction is occurring in the brain within this closed space within the skull, and so the pressure can build up significantly and rapidly within that closed space. There are the risk factors for IRIS with cryptococcal meningitis are the same as we see with other forms of IRIS, namely high baseline viral load, lack of prior ART, low CD4 count. Interestingly, a low white blood cell count in the CSF, again, that indicates advanced HIV disease because of a lack of inflammatory response before treatment was started, and a high burden of fungus on the CSF. But what can be really challenging is trying to distinguish between IRIS, treatment failure, or some sort of new CNS disorder. Now, and this is where the repeat LP is helpful, because with IRIS, you're typically going to have a negative fungal culture. I mean, in the setting of IRIS, treatment is working. It's just, in a way, it's, treatment's working fine, and the ART is working perhaps only too well. Whereas those with treatment failure will have positive cultures. Now, if a new CNS problem is ruled out, and if you can rule out treatment failure, and you really think IRIS is the most likely diagnosis, you want to continue treatment, both the antifungal therapy and the antiretroviral therapy, while carefully lowering the intracranial pressure if it's elevated, while also decreasing inflammation. And here we, for decreasing inflammation, we go to either NSAIDs in mild cases or systemic corticosteroids in severe cases. And there's some guidance here about the dosing and the length of the steroid taper, but as in virtually all cases of IRIS, that steroid taper is, it's highly variable from individual to individual, right? So you really have to monitor their situation and adjust your steroid dosing and taper accordingly. This also brings up a word about when do we start ART in people with cryptococcal meningitis who have newly diagnosed HIV disease, or who had not been on ART yet. So this is one of those situations where you actually need to delay the initiation of ART a bit. Both the United States and the WHO guidelines recommend delaying the initiation of ART for 4 to 6 weeks after starting your treatment for cryptococcal meningitis. And ideally, you get negative CSF cryptococcal cultures before starting starting ART. And this is backed up by a few studies that found a significant improvement in survival by using this approach. So that's CNS, that's cryptococcal meningitis. It's worth noting that we can see CNS mass lesions as well, cryptococcomas, just as we can see sort of fungus balls in the lungs. We can see them in the brain as well. They typically show up on CT or MRI. These are various images of it and what it can look like. The treatment is kind of similar to what's used for cryptococcal meningitis: induction, consolidation, and maintenance therapy, with these pretty much the same kind of treatment options. However, you may need to include these adjunctive therapies, including steroids, if there's a mass effect and a lot of edema, for example, just to decrease the inflammation. And for very large lesions, sometimes neurosurgery is required just to debulk and get on top of the treatment for them. And last but not least, let's talk a little bit about preventing cryptococcal disease. It's virtually impossible to prevent exposure. As I mentioned earlier, these species are worldwide. There may be especially high penetration or high prevalence of it among bird droppings. If there's something that can be done to avoid bird droppings for your patients, I guess it's worth trying to do so. Let's do one last poll. Which of the following statements are true regarding primary prophylaxis of cryptococcal meningitis for people with HIV who have CD4 counts less than 100? A, United States and WHO guidelines recommend prophylaxis with daily fluconazole. B, US guidelines recommend fluconazole, but WHO does not. C, WHO recommends daily fluconazole, but US does not. Or neither the US nor the WHO guidelines recommend fluconazole prophylaxis.
So let's go ahead and put our results for this in the chat, and we'll pick it up in there.
Yeah.
A, B, C, or D.
Okay. So give you a few seconds to think about that. Put that in the chat. All right, good. We've got a few responses. I can't see the chat, but I'll just go ahead and show you the results. So this is kind of an interesting situation where the WHO guidelines are actually more aggressive than the United States guidelines. WHO recommends daily fluconazole prophylaxis for these individuals, but the United States does not. The United States guidelines around this say routine testing for serum cryptococcal antigen in newly diagnosed HIV-infected individuals without any overt clinical signs of meningitis is, well, it's recommended by some experts for people who have very low CD4 counts. And if you get a positive result, then you should look for meningitis. If you exclude that, then treatment is indicated, and you treat the same way as you do for focal pulmonary cryptococcal infection. As I mentioned earlier, it's just fluconazole. But in the United States, primary prophylaxis is not recommended, right? And I think part of that is because in the United States, we don't have as high of a burden of cryptococcal disease. And, there's no clear evidence of survival benefit with prophylaxis. Furthermore, there are all these problematic drug interactions, the potential for resistance, et cetera. The WHO, on the other hand, and just last year, updated its guidelines, and they they do recommend screening for cryptococcal antigen in people with HIV before initiating or reinitiating ART. In anyone with a CD4 count less than 100, it would be reasonable to do so at less than 200. So that's kind of similar to the United States in the sense of, before starting treatment, if they have a low CD4 count, go ahead, test the serum CRAG. If it's positive, look for cryptococcal meningitis and treat. And this is the dosing that's recommended. Where it sort of differs, though, is that if you don't have that screening available, the WHO says go ahead and give prophylaxis with fluconazole to any person with HIV who has a C4 count less than 100, or maybe even less than 200. How long, the WHO kind of hedges on exactly how long to do it, sort of leaving this up to individual national guidelines, and gives a few examples. So just to summarize, and I want to leave us a little bit of time for discussion, cryptococcal disease among people with HIV occurs worldwide. It's especially high risk among individuals with CD4 counts less than 100. Establishing the diagnosis of cryptococcal meningitis requires clinical suspicion and the appropriate use of various tests and procedures, especially a lumbar puncture, ideally cryptococcal antigen testing. Treatment involves induction, consolidation, and maintenance phases for cryptococcal meningitis, ideally using amphotericin, flucytosine, and/or fluconazole. The CSF opening pressure should always be measured in people with HIV who have suspected cryptococcal meningitis, and should be lowered via sequential lumbar punctures if the individual has an elevated opening pressure. So I'll stop there and open it up for discussion, comments, and questions.
Thank you, Dr. Behrens, as usual, for an excellent presentation. So I will just ask a quick question, not so much a clinical question, and I see we have Dr. Siebert, Dr. Musa, and Dr. Edwards in the room, but more so in terms of a public health and systems standpoint, because one of the things that we are challenged with down here is availability both of testing and treatment. So, for example, right now we have no amphotericin B anywhere, right? And we had about 3 cases of histo in the hospital, 1 suspected case of crypto. We weren't able to test for it with the cryptococcal antigen. And some of these drugs, I think, in fact, all the drugs that are in the treatment recommendation of liposomal amphotericin B, flucytosine, fluconazole, are all on the pharmacostrategic fund as well as the WHO essential medicines list. So the question I would sort of put out is, how do we go about here, as well as in what recommendations for other territories? How do we go about accessing these testing agents as well as the treatment agents? Because there is some sensitization now around a study we're doing with CDC and PAHO with respect to histoplasmosis, cryptococcal disease, and tuberculosis. I think the outcome of that study might give a greater evidence base for which we could use as a lobbying tool to maybe move and shift some policy in this direction. But I'll just throw out that question because in too many instances, I think we are hampered by lack of diagnostic tools, as well as lack of the best treatments for the condition. So let's throw that out to anybody who's willing to answer.
My only comment would be at least that, what came out of the Ambisome trial was that it was a single dose of liposomal amphotericin B, as opposed to 2 weeks of it. So at least we're talking a lower quantity and thereby much a lower cost for the Ampho B.
Go ahead, Dr. Siebert.
Yeah, so thank you so much, Dr. Behrens, for a great presentation. Part of the activities that are on the ground right now, there's almost like a global group that has been doing work as it relates to some of these infections, Cryptococcus as well as histoplasmosis, is really trying to increase access to both supplies for diagnosis and treatment. So as you know, we are engaged in an activity right now to try and see how we can create a position to be able to present to the Ministry of Health to support access for the cryptococcal testing and the histoplasmosis testing on a routine basis. And then there's been a concession, I believe, by Gilead in terms of access to the amber zone for leishmaniasis and cryptococcus, not so much for histoplasmosis. And so that information has been shared, but it will put us in a funny position because we would get it for treatment of one disease, but we won't be able to use it for the other until such time that there's wider access. But that has been a long-standing challenge in terms of access for both diagnostics and treatment.
That's very informative. Before to any other questions anyone may have for Dr. Behrens? Whilst people are considering, Dr. Behrens, how much crypto do you actually see in Seattle?
Not very much. I don't think. I'm not doing. I guess I'm not. I can't remember the last time I saw it in, a case in the clinic where I work. Whether or not they might be seeing patients on the inpatient wards, but I think it's pretty rare out here. I definitely remember seeing it, when I first came to Seattle around 2000, seeing more of it. But I think it speaks to getting more and more people on ART and less people susceptible to it. So I can't give you firm numbers, but I think it's pretty uncommon. Is it how common is it in Trinidad? Would you agree that this is like a third of mortality for your people with HIV, or?
So we don't see as much of it as we do histoplasmosis. Histoplasmosis, we're usually hitting a case or two a month, fairly steady basis for a fairly long time. And I think we, for example, the study we're doing right now, I think we had the last batch of who's we tested. I think we got 9 positives for histo, so it's fairly common. But crypto is much less common. But the problem sometimes we have is that we don't have a good way to make a clear diagnosis. So, for example, we may have a case who would have come in with automental state. We did a lumbar puncture, and your ink is negative. We don't have crypto antigen. We see a still in between. So this could be a case. I'm not 100% sure. So, it's either TB meningitis or crypto meningitis, and everybody's afraid of amphotericin. So unless we have a confirmed or a really strong suspicion, we may avoid, taking that plunge because of how, if we do have amphotericin, most times it's, deoxycode, which is so toxic that we may sometimes delay on the particular diagnosis.
Yeah, it's very hard without cryptococcal antigen. Do you see any? Have you ever had cryptococcal antigen availability, or any hope from PAHO of getting that?
We did in the past, right? Well, so because remember, as an NGO, we were able to buy our own lateral flow kits. We were able to do ELISAs. The staff was knowledgeable and trained. That has become a little bit more difficult now. So the hospitals themselves had access to cryptococcal antigen testing for prolonged periods of time with interruptions in between. And right now we're in the middle of an interruption. So that's what's kind of compromising the care. So as Dr. Sebro said, I think there's a lot of activity going on right now to to Dr. Seymour's credit, she has been, ringing this bell for years now about improving access to fungal diagnostics, improving access to better treatments, options for persons with fungal diseases in Trinidad and Tobago, especially persons with HIV. And I think a lot of her dedicated work and pressure on this is probably now starting to come to bear in terms of building the case for it. So I think hopefully in the near future we should get from PAHO as well as from other agencies, a more persistent focus in making sure we have these tools and these medicines available on a round-the-clock basis. I muted myself and started talking again. So it's a minute after 3. So I think it's a good time to call an end to today's proceedings. I think, as usual, informative presentation, good discussion afterwards. Lots of things to sort of think about when we leave here, especially those of us who are involved in direct clinical care. So again, I want to thank Dr. Behrens for an excellent presentation. Thanks everyone for coming out. And we shall see you again at our next HIV STI ECHO session. Thanks so much for coming. Have a great weekend, everyone.
Okay. Thanks.